Good morning, everyone. This is the Orlando GI Journal Club for October. This is 7 a.m. Eastern Standard Time. Good morning, everyone. Our first study was published in Gut. This is a study from Japan looking at the real-world impact of implementing lumen-imposing metal stents for pancreatic fluid collections. Pancreatic fluid collections are local complications of acute pancreatitis. Lumen-imposing metal stents are increasingly used for endoscopic management of pancreatic fluid collections. This study evaluated the nationwide impact of implementing lumen-imposing metal stents on clinical outcomes in real-world settings in Japan. This was a retrospective cohort study looking at a nationwide inpatient database in Japan. Between 2010 and 2023, the authors identified 5,885 patients who underwent EUS-guided drainage of pancreatic fluid collections at 550 hospitals in Japan. The primary outcome was looking at an association between pre-lumen-imposing metal stent and post-lumen-imposing metal stent implementation in Japan and clinical outcomes. The LAMs were approved in Japan in 2018 September. From the database, 5,885 pancreatic fluid collection patients were identified who underwent EUS-guided drainage. In the pre-LAMS era, so this would have been using just all plastic stents, this constituted 3,787 patients. In the post-LAMS era, there were 2,098 patients. In the post-LAMS era, 733 patients underwent drainage using plastic stents, and 1,365 patients underwent LAMS placement. This is the baseline characteristics. The mean age was 63 years. There were more male than females undergoing EUS-guided drainage of pancreatic fluid collections, 70% versus 29.4%. In terms of the hospital volume, the majority, the hospitals in which there were 1 to 2 per year, and then increasing volume per, depending on the hospital, and the increasing volume, it was fairly evenly matched. Majority of the patients were pseudocysts. There were 10.6% of patients were definitely walled off necrosis, and 43.9%, in 43.9% of patients, the type of pancreatic fluid collection was unknown. The etiology of pancreatic fluid collections was acute pancreatitis in 51%. There were post-operative collections in 11.6%. Trauma was the etiology in 0.2%. Unknown etiology in 36.8%. In terms of the clinical outcomes, if you look at the treatment period, so pre-LAMS versus post-LAMS, again, remembering that some of the patients in the post-LAMS period also underwent plastic stent placement. In the post-LAMS era, there was a significantly higher rate of bleeding, 22.9% versus 15.2%. Also, significantly greater proportion of patients in the post-LAMS era required blood transfusion, 19% versus 13%. Rescue surgery was required in 0.7% in pre-LAMS era versus 0.8% post-LAMS era, which was not statistically significantly different. For post-procedural length of stay, the median number of days was 15 versus 15 days. Again, p-value 0.87. And in terms of total cost, calculated as US dollars, in the pre-LAMS era, it was $8,359 versus $11,639 in the post-LAMS era, with p-value of less than 0.001. When you're looking at just the post-LAMS period and then dividing that into LAMS versus plastic, if you look at the inpatient hospital mortality, the mortality rate was significantly greater in the LAMS versus plastic stents, 9% versus 1.6%. Rate of bleeding was again significantly higher in LAMS versus plastic stents, 29% versus 11.7%. Again, more patients in the post-LAMS period required blood transfusions at 4.5 versus 8.7%. And the post-procedural hospital stay was longer for LAMS at 19 versus 9 days, and total cost was significantly higher for LAMS versus plastic stents. And these authors found no significant difference in the need for rescue surgery. The main limitation of the study is that this is a retrospective study conducted from a nationwide database. The strength of this study is the sheer number of patients included in the study. However, this is offset by the fact that this was a retrospective study because they were not unable to conduct a maintain a prospective database for these patients throughout Japan. As a result, the quality and the information that you're able to extract from the database really is limited by how accurately the data are maintained and the type of data that are included. And so the authors say that in this particular database in Japan, key clinical details such as laboratory values and imaging findings are not available in the database. Also, they do say that in the post-LAMS era, so after September 2018, the Lumitrace metal stent were the only approved metal stent for use in drainage of pancreatic fluid collections. However, any off-label use of other types of metal stents are not captured in the database. Also, what this retrospective study does is support the findings of the randomized trials comparing metal and plastic stents for drainage of pancreatic fluid collections and ward of necroses and pancreatic pseudocysts, primarily a randomized trial that we conducted, which was the first one to be done, where we did also find that there was an increased risk of bleeding with use of LAMS versus plastic stents. And there was a shorter duration of procedure. And also we found LAMS to be more expensive than plastic stents. However, other clinical endpoints such as mortality, etc., we did not find significantly different between LAMS and plastic stents. Whereas here, if you look at the mortality rate, they do find this to be significantly higher in LAMS versus plastic. I wonder if this is because LAMS were used more often or primarily for drainage of ward of necrosis, which is the result of acute necrotizing pancreatitis, and you would expect those patients to be much sicker than patients with acute pancreatitis, maybe resulting in pseudocysts, in which case maybe plastic stents were favored. It's difficult to say. So the take-home point is that the implementation of LAMS was not associated with improved key clinical outcomes, but was linked to a higher risk of bleeding and increased healthcare costs. These findings do not support routine use of LAMS for EUROS-guided treatment of all PFCs in standard clinical practice, but may restrict it to patients with ward of necrosis with clear indications. Our next study is our randomized trial published by our group in GUT. This is looking at endoscopy versus surgical gastroenterostomy for patients with malignant gastric outlet obstruction. The surgical gastrojejunostomy is the traditional treatment for malignant gastric outlet obstruction. However, longer recovery time may be needed for recovery of gastrointestinal function, and it is known to cause a potential delay in resumption of oral intake, and hence hospital discharge and provision of chemotherapy and treatment of underlying cancer. Duodenal stenting is a less invasive endoscopic option. However, it is associated with high rates of stent dysfunction and need for frequent reintervention. US-guided gastroenterostomy is a newly proposed minimally invasive approach to bypassing the obstructing tumor. So there have been several meta-analyses published on this topic. This one from Endoscopy International Open, published in 2022, including 6 retrospective studies, so not good quality studies, comprising 484 patients. They found that clinical success between US-guided gastroenterostomy and surgery was similar. However, there were fewer adverse events in the US group. So what we wanted to do was conduct a high-quality, multi-center randomized trial to determine whether US-guided gastroenterostomy is superior to surgical gastrojejunostomy in patients with malignant gastric outlet obstruction. This is a multi-center superiority randomized trial conducted in 3 countries, USA, India, and Germany. We included patients over the age of aged 18 and over with radiological and/or endoscopic diagnosis of malignant gastric outlet obstruction with a scoring system score of 1 or 0. That means they're able to just tolerate liquids. And the patients had to be amenable to treatment by both EUS and surgery. Patients were randomized in a 1-to-1 ratio to undergo either EUS-guided gastroenterostomy using luminal metal stent, hot Axios, or surgical gastrojejunostomy using either minimally invasive approach or open, depending on the feasibility at the time of surgery. The follow-up was 6 months or until death. The primary endpoint was a composite measure of the gastric outlet obstruction score, the GOOS score of 0 or 1 at the time of hospital discharge, need for additional endoscopic or surgical interventions, or need for supplemental nutrition at any time during 6-month follow-up, and procedure-related adverse events. Secondary endpoints were time to advancement to solid food, duration of hospitalization, mortality, time to chemotherapy, quality of life, and treatment costs. So when we looked at the composite endpoints, so again, our composite endpoint was comparing a negative endpoint, so able to only tolerate liquids and/or need for reintervention or supplemental nutrition, or procedure-related adverse events. And as you can see, the composite endpoint was significantly lower, so outcomes were better for EUS at 7.9% versus surgery compared to 38.9% for surgery. So this difference is 31% between the 2 groups with p-value of 0.002. When you look at the individual components of our composite endpoint, all patients in the US group were able to be started on a solid diet at the time of discharge, compared to 80.6% in the surgery group. And the need for reinterventions or supplemental nutrition was significantly lower in US at 5.3% versus 33.3%. And there was no difference statistically between the 2 groups in the instance of procedure-related adverse events. When looking at the individual adverse events, again, as mentioned earlier, there was no significant difference between EUS and surgery in the instance of procedure-related adverse events. When looking at the overall disease-related adverse events, again, there was no difference between the two groups at 73.7% in US versus 72.2% in surgery. And there was no difference in mortality between US and surgery, with p-value of 0.163 and with mortality rate of 57.9% versus 41.7%. Now, when looking at the secondary endpoints, US was also superior for the following endpoints. We were able to start solid diet quicker with EUS at 2 days versus 5 days for surgery. This is p-value of 0.001. The procedure duration was significantly shorter for EUS at 25 minutes versus almost 2 hours for surgery, p-value less than 0.001. Duration of hospital stay was significantly shorter for EUS at 3 days versus 9 days for surgery. That's p-value of less than 0.001. Also, we were able to start chemotherapy quicker in the US group at 21.5 days compared to 35 days for surgery, p-value of 0.011. There was no significant difference between US and surgery for readmissions, the proportion of patients undergoing chemotherapy post-procedure, mortality rate, and time to death. Also, EUS was superior to surgery in terms of quality of life. We found the physical and social functioning at discharge was better for EUS, and also symptom scores for nausea and vomiting were better for EUS at 6 months. When looking at total cost, it was also significantly lower for EUS compared to surgery at $33,934 versus $51,437. The limitation of this study is that blinding was not possible due to the differences in the treatment modality. So, there's a big difference between US and patients undergoing surgery. And so we were not able to blind either patients and trial personnel were not blinded. And so this is a potential source of bias. Next, 58% of patients in the surgical group were unable to undergo laparoscopic or robotic surgical gastrojejunostomy and underwent open surgery instead because laparoscopic or minimally invasive surgical gastrojejunostomy was just not technically feasible. However, when we conducted secondary analysis looking at primary and secondary endpoints between patients undergoing minimally invasive surgery versus open surgery, there was no difference in either primary or secondary endpoints, and we feel that this is reflective of real-world experiences in surgical practice. In conclusion, in this multicenter randomized trial, US-guided gastroenterostomy was superior to surgical gastrojejunostomy in palliating malignant gastric outlet obstruction from both clinical and economic point of view. Therefore, US-guided gastroenterostomy should be the preferred treatment approach when requisite expertise and resources are available for management of patients with malignant gastric outlet obstruction. So, recap for Journal Club for this month. Inflammation of LAMS was not associated with improved key clinical outcomes, but was linked to a higher risk of bleeding and increased healthcare costs. These findings do not support the routine use of LAMS for US-guided treatment of all PFCs in standard clinical practice, but may restrict it to ward of necrosis cases with clear indications. In this multicenter randomized trial, US-guided gastroenterostomy was found to be superior to surgical gastrojejunostomy in palliating malignant gastric outlet obstruction from both clinical and economic point of view. Therefore, US-guided gastroenterostomy should be the preferred treatment approach when requisite expertise and resources are available for the management of patients with malignant gastric outlet obstruction. Thank you for joining me this morning. Our next monthly GI Journal Club is on November 5th, 2025. I thank you so much. Please have a wonderful month, day, week, and month. Thank you. Bye.